Welcome to Clear the Air with me, Angela Lim, medical doctor and co-founder of Clearhead, an innovative employee well-being platform. Clear the Air is a podcast covering those experiences in your life or questions you have that you feel too vulnerable to share with those around you, such as, why do I feel so lonely? And what can I do to feel happier? We get real and raw on these existential questions on mental health and well-being that's puzzled humans for millennia, sharing the science behind what you're experiencing and the answers behind those questions.
Trauma can take many forms, from single shocking events affecting a whole community to deeply personal experiences that unfold over time during childhood. We'll explore how different types of trauma, such as traumatic brain injury, post traumatic stress disorder, and more, can negatively impact our behavior, relationships, and resilience later in life. Understanding how it affects us can be one of the first steps towards recovery. In this episode, we will cover what really happens to the brain and body after trauma and what evidence based interventions help people rebuild their lives and what that looks like in clinical practice. Our guest today is Dr. Jan Ewing. She is a highly respected clinical neuropsychologist and clinical psychologist with over 40 years of experience specializing in trauma, brain injury, and complex psychological disorders. As a fellow for the Australian Psychological Society, the Australian Society for the Study of Brain Impairment, and the International Study of Trauma and Dissociation, Jan is recognized internationally for her expertise in understanding how trauma impacts the brain and behavior. She has trained thousands of mental health professionals across Australia and served for more than 15 years as an educator at the University of Queensland. Jan also sits on the advisory panel for the Blue Knot Foundation, which supports adult survivors of childhood abuse. Welcome, Jan.
Thank you very much. Thank you for inviting me.
Oh, Jan, that's a very interesting background that you have. What actually made you decide to go into the field of trauma?
Oh, that's a good question. I think I just was led into it by the patient. Really, I trained originally as a clinical psychologist. Then I went on and did clinical neuropsychology, and then I think when you're seeing a wide range of patients, even though I wasn't trained very much in trauma treatment in my postgraduate training, trauma just keep walking through the door. And so I think in the end, you have to be able to treat trauma. And I had to go off and learn a lot more about treating trauma because you ignore it to your detriment. And when you've got patients, you're not sure why they're not getting better because you've not uncovered that there's underlying trauma. You have to start to work out what's going on. So I think really the patients taught me that I needed to know more about trauma, and I've been learning about trauma ever since.
Mm. So, how do you define trauma? And so, what did you kind of learn more about trauma that you didn't know in your initial studies?
Well, I think I didn't really understand the impact of trauma. I think patients don't understand the impact of trauma. So I think both of us originally were not able to recognize that trauma was sitting in the body, that trauma was actually underlying a lot of the interactions that they were having with other people, particularly childhood trauma. And so I think adults who've had a single event of trauma are much more able to identify that that's what's changed their life. But when you've had it all through your childhood, and you've just found ways to cope, it becomes a part of who you are. And I think then it's a lot um, less common. I've had so many people tell me, I had a good childhood. And then when you actually dig into that, you discover that actually this good childhood was actually a very traumatic childhood, but it just had become normalized for then, if this was what normal life was. So, trauma can be defined in many different ways. So, in order to get a diagnosis of post traumatic stress disorder, the trauma that we need to have been exposed to or witnessed is where you've been exposed to or witnessed a serious threat to life or physical injury or sexual violence, or you've witnessed that happening. And so that's where there's been a threat to your survival. I think I would add into that, which isn't part of the classical diagnosis for PTSD, that there can also be threat to psychological survival, particularly in childhood when you're dependent on others for survival. And if those others are also the source of your threat, then there can be a psychological existential crisis as well, which can become a traumatic event over time. So, trauma is a survival response. It's about when you've been exposed to a situation where your normal coping mechanisms have been overwhelmed and your brain has gone into survival mode. And then, in order to get the diagnosis of PTSD, what's supposed to happen after that? That would happen for all of us. The brain is a survival organ and beautifully designed to maximize survival if we're exposed to a major threat. So we're all supposed to go into survival mode, and luckily we all do. But what's supposed to happen afterwards is that the brain will re-regulate and bring you back to normal regulation, and then you're able to process what went on, make the peace with it, and move on. It's when that process gets stalled for a whole range of reasons that we start to see symptoms of post-traumatic stress disorder emerge.
Mm. Yeah, and you said that you actually really like to use the your hands as a way of describing this model of what happens to the brain in the context of trauma, whether it's, as you said, a threat to your actual survival or even psychological safety. So, would love for you to maybe expand a little bit more on what happens to the brain post trauma.
So I will get everybody, it's easier if we do this visually. So I'll get everybody to have your hand up with your palm up. I'd like you to put your thumb into the center of your palm, wrap your fingers around that and back to the thumb. So there's 3 different systems that we're going to be explaining. I'm probably going to use some terms that you won't be familiar with, but I'm hoping by the end of it, you'll understand what I'm saying. So there are 3 different systems. One's going to be the regions of the brain that I'm going to explain that are particularly involved in survival. One's going to be what we call the autonomic nervous system, the sympathetic parasympathetic nervous system, which is the part of the nervous system that gets you up and ready for survival or shuts you down. And we're also going to talk a little bit about, very little bit, about the neurohormones that get activated when we're in a survival situation. So this is your brain. So I want you to think of your arm is your body with the spine going through it, coming up to communicate with the brain, which is your hand wrapped around it. So here at the wrist, we've got a lot of interesting things going on. So here at the brain stem, the very back and base of the brain, we've got some structures there called the periaqueductal gray, which are your threat detector parts of the brain. So they are the ones that are going to notice that there's a threat before you're anywhere conscious aware of it. This happens way before conscious awareness up here happens. So you're walking along a path, you see something, you've already stopped before you've thought, is that a snake? Right. And so then that will travel up, come around your frontal lobes here, will check whether or not it's a snake, will decide it's a stick, and will allow you to re-regulate and go on. So that's what would normally happen. So that's the periaqueductal gray, which are very involved in that startle response. Through here are also coming the nerves, the vagus nerve and the sympathetic nerve chain, which are the parts that are going to get the body up and down, as I said before. So the parasympathetic nerve is the one that people are talking about a lot at the moment with the vagus nerve. That's particularly involved in parasympathetic arousal. We'll come back to that. So coming up here, we're coming up to the brain that wraps around. Inside here, hiding inside the palm, we've got a part of the brain called the limbic system. So if you look at your thumb knuckle, we're going to call that the hippocampus. That's to do with memory. And it's to do with moving memory of what's happening now into being processed into long-term memory. And we'll call the thumbnail the amygdala, which is your little alarm center, fight and flight center. Wrapped around that is the frontal lobes, which, as you can see, communicate back down to the limbic system. And so they're very important in regulation of that alarm system inside. So what will happen is if the periaqueductal gray and the amygdala, your thumb, have detected a threat, they will start to activate, the sympathetic nervous system will start to activate down to your body to get your heart rate up. Heart rate starts pumping to get blood to your hands and your feet, so you might be able to get ready to either defend yourself or run. And it starts your neurohormones of cortisol and adrenaline will start to be released to get your body ready. And up here, the amygdala is now starting to affect the brain. So if your frontal lobes are still online, it'll be checking to see whether this is a real or a false alarm state. As I said before, it might be able to regulate down and go, no, everything's okay. While these frontal lobes are regulating and down, you're still able to think, you're still able to plan, you're still able to make decisions. So if the threat's a long way away or it's building, you can make some decisions about what to do. But if it's a very unexpected major threat and you're suddenly overwhelmed, then the amygdala is going to start to turn the frontal lobes off. So you'll start to flip your lip, if you like. So they start to get inhibited, particularly this left frontal lobe, which is to do with speech. So your ability to speak during a major crisis is often impaired. People will say, "Why didn't you call out?" It's I couldn't speak. Also, your ability to do self-talk starts to be impaired because your left frontal lobe is being inhibited. So the amygdala is starting to turn that off, and it's starting to turn it off for a good reason, a survival reason, which is if you're going to just be dilling around about what do I do, it's too slow. And if you're in a major survival threat, then you need to stop dillying around and you need to just do something that's going to make your survival. So that's where the frontal lobes turn off a little bit. And increasingly, as the threat gets bigger, if it was a major, huge, overwhelming thing, they might just get inhibited immediately. Otherwise, it might come more gradually, coming more and more frightened as you come along. And so then you'll be going to either an instinctive response, fight, flight, freeze, flag, fawn, submit, and faint. I've got those in slightly wrong order, but I'll talk about those in a minute. Or if you've had training and drills, which is why the army trains their soldiers for a year before they go to war, so that they don't just go to flight, which honestly, if you're a sensible person, you would run. But if you've got training and drill, this can be changed by experience. So you will go to whatever you have learned the best to survive in that situation if you've been exposed to that situation before. So there is a learning aspect to it as well. So if you've learned that fight is the best way, you'll more likely go to fight. If you've learned freeze is the best thing for your survival, then you're more likely to go to that. So the more you've experienced that, and the more you've been drilled in that, the more you'll go to that. So all of this happens really quickly. It all happens before you know that it's happening. And so the frontal lobes come offline, your amygdala will send you into whichever one your brain thinks is the best for your survival and or your drilling and training. You'll do fight. So the cascade is generally a startle, and it goes up with the sympathetic nervous system, starts to get the system up into active defense, fight or flight. Then if it continues and fight and flight are either not available or they're stymied in some way and blocked, you can get to the top of that cascade where now the parasympathetic nervous system comes on board and puts you into a fright position. Fright is that spot, you'll see a lot of animals in this, where fright is where it's what we would call an active immobilization. So the rabbit who has suddenly frozen but is ready to run the minute the predator loosens their jaws or the minute the predator looks away. So that is fright, where you're still highly activated. You still could put fight or flight into place if there's an opportunity, but you're frozen for the moment because that's in your best interests. A frozen prey is often less likely to be caught than a running prey. So if that then continues to be life-threatening and that's not working, then the dorsal vagal system will kick in, the parasympathetic nervous system will kick in, and will now start to shut you down. So that's when it may go to fawn, which is where you're trying to release the whoever it is that's hurting you, or it'll go to flag, where you get very floppy and tired and sluggish and start to slow down. And at the end of it, it'll go to faint or a play dead. So for some animals, they'll go to play dead in microseconds. And for some people, they will go into a faint in microseconds because that's what they have learnt is the safest thing for them to do in a particular situation. For some people, they are much more likely to go to fight because especially if you've been drained on shit. So that's what's going to happen. You're going to do whatever your brain thinks is best. Often it is the best thing. Sometimes it can be actually not the best thing, but it usually is for a good reason. And then what's supposed to happen after that, after it's over, you've realized you're now safe, then all of that comes back online again. So the frontal lobes come back, re-regulate, tell the amygdala all is well, tell we're safe now. Everything starts to calm down. The system starts to re-regulate itself. And when it's fully re-regulated, which can sometimes take some time, like it can take weeks before that has fully re-regulated, then you can start to process. So during that time, during survival mode, our little knuckle here, the hippocampus, which is to do with moving memory into remote long-term memory, has been inhibited because there's no point trying to remember things when you're just trying to survive. But as it comes back online, then the processing of memory starts to come through. And so then we have the system starting to work out what happened, see it from a point of safety and I've survived, and make their peace with it in whichever way they need to make their peace with it. What happens for some people, though, is that process of re-regulation is disruptive. Now, it might be disruptive for a whole lot of different reasons. It might be disruptive because it's not safe to re-regulate. You actually need to stay in survival mode. So if you're a child living in a dangerous household, it may never be safe to fully bring that down and start to process. It may also not be safe because you don't want to know that your household is unsafe. So you dissociate that away from your conscious knowledge. If you're in a war zone, it's not safe for you to re-regulate, start processing about the death of the person you just saw in front of you, or because you have to stay vigilant. It might be that every time you try to process it, it just is so overwhelming that this whole system dysregulates again. You can't process if your frontal lobes are not online. And so if they keep going offline every time you try to process it, then that means it'll get stalled. And it may be that you've never had really good connections between your frontal lobes and your limbic system, so that when they get wildly dysregulated like that, it's very difficult for them to come back and regulate your brain, because developmental trauma has meant you haven't got great pathways to help you do that. So when that happens, we start getting the symptoms of post-traumatic stress disorder, there are four main symptoms, and they make sense in terms of what's going on in the brain. So one is intrusive symptoms, because the brain is trying to process what went on. It's its natural thing to do. So you might have nightmares, you might have intrusive thoughts, you might have intrusive feelings coming through, you might have reactivity to reminders, so sudden intense distress because you've suddenly had a smell that reminded you of something, or something reminded you of something. So there's a whole lot of intrusive experiences. So, but every time they're happening, what happens is the brain tries to shut them down because it's so distressing, and that gives rise to avoidance symptoms. So then we have a whole lot of avoidance, not wanting to go anywhere where you might get a trigger. No, I don't want to go to the same places. I don't want to talk to the same people. I don't want to do anything that reminds me of this. I don't want to think about it. And so there's a whole lot of avoidant symptoms. Those avoidant symptoms can often give rise, if this goes on for a long time, to secondary avoidant symptoms that are trying to help keep it all out of your mind, like alcoholism, drugs, keeping really, 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 really busy, having OCD in terms of trying to keep your environment very controlled, because the control allows you to feel you've got more control internally and externally. So that's the avoidance symptoms. And then there's a set of hyperarousal symptoms, because now the system has not re-regulated. So we've got chronic hyperarousal. So your little periaqueductal brain is constantly looking for threats. So there's hypervigilance all the time, constantly looking for threat. What's behind me? What's over there? What was that noise? Your amygdala is humming all the time. So not in full survival mode, but not out of survival mode either. So you have exaggerated startle response to sudden noises. You have difficulty falling and staying asleep. You have irritability and sudden outbursts of anger. You have sometimes reckless behavior. Sometimes you have people who are re-exposing themselves to the similar situations, or get to become adrenaline junkies, because they're trying to solve it by having more exposure to it rather than processing what happened in the first place, and often get more trauma. And then the last lot of symptoms are symptoms. Trauma often shatters people's view of themselves or the world and/or the world. So they move from, "I always thought I was in control," to, "I have no control whatsoever," or, "I always thought the world was a safe place. There's no safety anywhere." Tends to be very black and white. Or, "It's all my fault. I'm pathetic." Or it's, it might be, "I need to I need to never, ever, ever have my guard down ever again. So people with PTSD hate surprises. So, don't give a surprise party to someone with PTSD. So I must always know what's going to happen. I must always have everything predictable. They often start to develop, it's a high risk of suicide because it just feels it's a really horrible place to be living with that dysregulation all the time and constant startling. So suicide becomes a problem. And so there's a whole lot of negative beliefs and cognitions that go with it as well. So they're the four symptoms that are all telling us that the brain has not re-regulated and the trauma has not been processed. So I hope that made sense. That's a long answer to your question.
No, it's so good. And I think for people who may have been in situations where, for example, something shocked them and they were lost for words, now they understand why that happens. Or if someone sees blood and then they just faint, now they understand why that happens. Um, and you mentioned this. You mentioned that actually the re-regulation could take time. Is there in the research a normal amount of time? Because you did sort of caveat it in the context of it has to kind of be safe for you to do it. So if you're at war for a year, for example.
Oh, exactly. Well, I mean, I've seen, well, I mean, for instance, if you're a child living in a frightening and unsafe household, then you may never, through your whole childhood, be able to re-regulate your brain. And unfortunately, that means during childhood is when we learn because our frontal lobes are developing until we're in our mid-20s. So this is the time, especially in the first 10 years, we're developing the pathways that help us re-regulate ourselves. Babies can't regulate themselves at all. And then slowly, by the time you get to school, you're able to regulate yourself enough to put your hand up to ask a question. Um, and then, by the time you're a teenager, you're expected to be able to regulate yourself enough that you're starting to organize yourself a little bit more independently and so on. This is an ongoing learning curve. But if you're in survival mode through most of that, then you don't get that same amount of ability to form learned pathways in how to regulate your brain. So people then start to use other methods. They start to use avoidance. They start to use dissociation, which is a part of isolating our experience. And I just don't want to know about it. Um, they will start to go into self harm, or they'll go into becoming, as I said before, they might become very over controlling. Um, they might use anger. They might use all sorts of maladaptive ways, but they're the only things that they're reaching for. Or they might use withdrawal and become very withdrawn. They just have had using whatever they can to try to cope because they don't have that capacity to regulate themselves. So after a single event, the traumatic event, you can't even get the diagnosis of PTSD for a month. So it's absolutely normal to still be dysregulated after several weeks, depending on the nature of what's going on. But if you've had a major overwhelming crisis, and there are all sorts of we haven't talked about different ways, different types of trauma, but we will, I'm sure. But there's lots of different types of trauma. But if you've had a major overwhelming and you've been really fully dysregulated in survival mode, it takes some time. And so the diagnosis of post-traumatic stress disorder is not available until a month after. If you've still got those symptoms after a month, then we start to be more concerned. But symptoms of overactivation, as long as they're coming down over those first few weeks and things are starting to settle, that's as it should be.
Hmm.
So some people, if you don't have a snake phobia and you stopped in the street and thought that was a snake and then realized it was a stick, then you can settle down in moments. You can go, oh, for a moment there, I thought that was a fake, and you're talking to yourself as already coming back online. So, and you go, then you take a big breath, go, and you settle yourself down, and you might still be a little bit jittery at the end of that, but you've basically started your regulation already. If you've got a snake phobia, you probably haven't even stayed around to check whether or not that was a stick or a snake. You've just got out of there. So you've kept yourself safe, but you haven't actually been able to check whether or not it was necessary.
Mm. I'm just really conscious, obviously, of, whether that's an individual encountering trauma or someone who's supporting an individual, when they should intervene in this. It's obviously really hard during this weeks long period, And so, especially for example, Clearhead is an EAP provider. So sometimes we get workplaces giving us a call and saying, like, oh, we just had a bank robbery. Everyone's really frightened from it. What should we do, so that like our employees don't get traumatized and develop PTSD. So what do you recommend in the context of either a support person or manager in those kind of situations?
Yeah. Well, what I don't recommend is getting them all to talk about it straight away because they're not going to be able to do that. They're just going to keep re-triggering this dysregulation every time it comes up. So because you can't process until you're safe. So the first thing is to get them safe, and they need respect. They need to not be patronized. They need to have an understanding about this. This is a biological thing that has happened to them, and it's very understandable that they might be dysregulated. So I think to begin with, some respect and non-judgmental thing is very good. Then having social connection. So getting someone that actually they consider to be a supportive person, someone that they're close to, getting a family member or a work colleague or someone that is actually close to them, because when you've got someone who you know cares about you near you, you release oxytocin. And oxytocin is a natural inhibitor of adrenaline. It brings it down and helps you re-regulate. So just having someone there helps you start to settle your bodily symptoms. So the first thing we need is safety. We need to get that they feel safe, they feel understood and believed, and they feel protected. And then we want to make sure that there's some choice and collaboration on what's going to go next. So, and workplaces, there's a lot of advice out there about trauma-informed care. So I would recommend they all read it and look at it. But safety, choice, and collaboration are the sort of pillars. So that rather than telling them what's going to happen, it's about what do you need, um, and what's going to help you feel safer. And a lot of it is about making sure people have got good training on how to manage the sorts of things that they're going to. I think the army is actually very good at training. They're not very good at debriefing afterwards, but they're very good at training. So I've treated a lot of military veterans, and most of them will say the things that they encountered where they had, because they had good training, they all consider they had good training. It wasn't the things they encountered that they were trained for that were traumatic. It was the things that happened that you can't train for, or that went wrong, or that were sudden, overwhelming, unexpected, rather than the things you trained for. So good training, of course, in the army that's one case, but that's also the case for any occupation where your workers might be exposed. So this is prior to the trauma. There needs to be good training, but also afterwards, it's that okay, we need to do more training to help people feel that they've got some mastery. Because when you know what to do and you've got mastery, you can keep the frontal lobes line longer. And also, if they start to come off, you'll go to your drill anyway. So, so training is important. Having support is really important, and then collaborating with them as to what it is you need now, and then only after everybody's well regulated, and that could be very different for some people. That is when you would want to do some processing. So I wouldn't have everybody in the group all talking about what happens with them, because you're going to have one person talking about who's really ready to talk about it, and someone else who's not, who's going to be offline and back in the trauma, and not be hearing a word of what's going on, but be really reliving their trauma. So that needs to be done on a very individual basis, and it needs to be done with someone that they feel that they've got a trust and support in. So preferably a therapist, but it can also be someone well trusted who's able to help keep them in what we call the window of tolerance. So the window of tolerance is where you're in a regulated state. You've got your sympathetic and parasympathetic nervous system both in balance, and you're able to talk about things without getting too hyper aroused or too hypo aroused. So you're not going to, you might still be aroused because you're talking about something that's distressing. I'm not saying that you've already processed it, but you're able to keep your frontal lobes online when you're in the window of tolerance. It's often easier when you've got someone that you trust in the room. Right? If it goes too high, if the arousal starts to go too high, then you have to be the person themselves needs to be able to notice, I'm now starting to lose it, and so do the people trying to help them through it. Because once you've gone too high, there's no point continuing the conversation. If you go too low and you to shut down and go into the flag faint stage, then you're also not going to be able to process. So our aim is to do the processing in the window of tolerance. Now, some people have got quite a broad window of tolerance because they've had a stable background and they've learned good regulation skills and they've come through to adulthood with pretty wide window of tolerance, and they've just been overwhelmed, and so we can move on with them to work through the trauma pretty quickly because we just reestablished their usual general window of tolerance, and they're able to stay in that window of tolerance while they're processing. If they've come through childhood adversity and, as we've said, they haven't got a very good capacity to stay, they've got a very narrow window of tolerance, then we need, for that person, what we need to be doing is helping them stay and widen their window of tolerance. So they're going to need a much longer way of going about this, where the first part is all going to be about just getting their system to be regulated and teaching them self-regulation skills, to be able to keep themselves, their frontal lobes online before they're going to be able to do the processing. Does that make
Mm,
sense?
totally. I think one of the things that's kind of interesting for me is as you're describing all of this, it sounds to me that if you're truly in that space, it's actually you're in a very uncomfortable space. Your mind's not working the way you think it should. Your body's just hyper alert. You're just not relaxed and enjoying life, as you said, and therefore higher risk of, uh, negative coping behaviors including self-harm and suicidal thoughts. And so, but you at the same time also said that you had people come to you at clinical practice and either you or them wasn't immediately aware that trauma was the underlying mechanism of why they've showed up. So where's the disconnect there in terms of how does trauma present in clinical practice and how do you go, let's work on this?
Yes. Well, I think one of the things that's often not understood is body memories, where people will have an intrusive memory, but it's a body memory. It can be a sudden rush of adrenaline. It can be a stomach drop. Uh, it can be a sudden smell coming through, but it doesn't come with content. So they're not aware that that is actually a memory because we think of memories as pictures in our heads, right? And so if it doesn't come with the picture, and because it hasn't been fully processed, it often is very fragmented in terms of which bits of the memory come through. They don't come through as a whole. So I think one of the things that I started to understand more was recognizing bodies that are actually holding trauma, and that the patients themselves are not aware that that's what's going on. So people who hold themselves in particular, some people will hold themselves in a very collapsed way. Some people hold themselves in a very uptight way. Then the startle response is also a giveaway. So if a phone goes, then and they're jumping out of their seat, that's probably a pretty real a giveaway that something's going on. So, in fact, with the startle response is interesting because when we all have a startle response, it's part of our survival mechanism. But when you don't have PTSD and the same thing keeps happening, the same noise or the same thing that frightened you the first time keeps happening, we do what we call habituate. We get used to it. So if you're living next to you've just moved in next to a train line, and the first few nights when the 3 o'clock train in the morning comes through, you're jumping out of your bed going, "What was that? Sounds like the train coming through my bedroom." By the time you've lived there for a few weeks, you don't even wake up. The train just goes through because your brain has worked out this is not a survival problem. Your frontal lobes are feeding back without even waking you up about it's just the train. And so we habituate. With post-traumatic stress disorder, the the brain has decided for good reason that it's not safe for you to habituate. So if this was a threat that was once life-threatening, you need to never habituate to that threat. Otherwise, your life could be in serious threat again. So it will start to not habituate to anything that might potentially be that. And that gets over time gets down to it's just got to be a whiff of it. So just a little bit of it. So if you were, I didn't warn people at the beginning. I might use things that are disturbing. So look after yourself. But if you grew up with a father that was abusive whenever he was drunk, then you will learn just by how the car door closes whether or not you need to get ready to fly, um, or just the smell of alcohol. So in later life, you might not know that that's what's going on, but the minute you smell alcohol, you freeze, or you get angry, or you respond in a way that was once part of your survival mechanism, but it's no longer connected. And that can be particularly the case if there's amnesia, and there often is amnesia for parts of because the memory processing didn't go through properly. There's often amnesia for parts of the trauma. So then you can have intrusive symptoms that you have no idea where they're coming from because you don't remember it happened.
And so you've mentioned this a few times now that actually it sounds like the pathway to recovery for trauma is the ability to process what happened. Maybe you could share a little bit. What does it mean to process the trauma? What do you do in clinical practice to help someone process the trauma?
Yeah, absolutely. And so safety first. So, as I said, we've got to make sure that the person is in their window of tolerance before we do processing. So with really complex trauma or trauma that has become really chronic PTSD or complex PTSD, then we would do a 3-phase model. So the first phase would be safety, symptom reduction, emotional regulation training. Second phase, trauma reprocessing. Third phase, reintegrating, rehabilitating in a new way of being. So in the trauma reprocessing work, let's assume that we've got to where we're able to keep somebody in the window of tolerance. And we may have to break up what we're going to process. So it might only be we're going to just do the first 5 minutes, or we're going to just do the very first bit of something, or the very first trauma. So we break it up and don't overwhelm somebody. So then, we will then have what we're trying to do, and there's lots of different techniques that do it. So first thing I would probably say is if you're going to be the therapist and you're looking for a therapist, it's a therapist that hasn't just got one therapy that they do. In my point of view, you need someone who is going to be able to adapt a whole different range of treatment models to match you, because everybody's a little bit different. Some treatment methods really suit one person, fantastic, and everyone goes, this is the one you've got to do, and it might not suit the next person at all. So we have different treatment models for different people, for different traumas, for different backgrounds, and so on. What we're trying to do is move from re-experiencing, so that whenever you think about it, it's as if it's happening again. Your body's back in the state it was in at the time of the trauma. It feels like it's happening again. You might be in a flashback, or it feels like it was only yesterday. It feels like it could be happening. That re-experiencing, bodily re-experiencing, mental re-experiencing, that's what PTSD is. It's a constant re-experiencing. So it's a horrible place to be living. And what we want to do in reprocessing is where we allow the hippocampus to come back online because we're regulated, and we move from re-experiencing and involuntary re-experiencing to voluntary remembering. So when somebody is telling you about something, it's just, I can just feel my stomach go as I think of it. I'm breaking out in the sweat as I think of it. They're re-experiencing, as opposed to someone who has processed it, who's able to do, I remember that I felt this, or I remember that I was doing that. So it's I remember that rather than I'm feeling it right now. And so there's lots of different techniques to do that. Some people will think they've got there. They'll tell me, oh, I can talk about it. It's fine. But actually what they're doing is emotional numbing. So one of their ways to avoid is to numb out. And so this is a dissociative symptom where you numb out so you don't feel anything at all. They start to be like the ice person. They don't feel anything. They sometimes get quite worried about themselves because of like, so and so died, and I know I should be sad, but I can't feel anything. Or I go and do things, and it's nice, but I never feel really happy. They just have numbed out all emotions because emotions have become dangerous. So they can say, oh, I can talk about it, but they're not actually processing it. What they've done is dissociated the whole thing, including the emotions, away from us. So we have to be able to distinguish the difference between someone who's fully processed it and someone who's dissociated it.
So much complexity, but it sounds like, that there is a step forward, and obviously some of the stuff that we're talking might be triggering for people as they listen. Want to just kind of share, that you don't have to suffer alone, that there are professionals out there. And if one didn't work for you, that you might just need to try a different person who have maybe different therapeutic modality. And, Clearhead is an EAP provider. And so we are able to provide you funded support through your employer if they use us as well. So please don't suffer alone. Please, ask for help. And you don't, it's not a stigma. It's basically you being human, reacting normally to danger, and unfortunately, somewhere along the lines, the body got confused, and it didn't get back to where it needed to go. Until someone is processed the trauma and done the recovery work, and it sounds like usually with a professional, how does it manifest? How would I know, if someone hasn't walked into a therapist's room, that they are maybe how they are reacting or behaving is a form of trauma, and what can I do so that I either don't trigger them or make things worse?
Oh, that's a tough question. I think knowing the symptoms of PTSD. So when someone is very avoidant, and often what you'll find with avoidance is what I call the funnel effect. So they'll say, I can go here, if you imagine a funnel, but those that can't see. I can go here, everything's okay as long as I just stay in this section of my life. I don't go there anymore, I don't go there anymore, I go here. But then something triggers them inside that thing. So then rather than go, oh, I need to learn how to manage that better, they will say, okay, I'm not going to do that anymore. And the funnel gets a little narrower. But they start to restrict their lives. So I'm just going to do and see and talk about the things that I can manage. And then something will trigger them in that. And then they cut that out of their life, and they cut that out of their life until they're really very withdrawn, very isolated, don't want to go anywhere, don't want to do anything, don't want to talk about anything very much, tell you that they're fine. Often they feel like, I think maybe if I just take off, I'm just going to go camping in the wilderness for 6 months and then I'll be fine. Or they might move house all the time because they're blaming the neighbors as being the problem. So they're right down the funnel, becoming very isolated. And down there sits depression, because not only have they moved all of the stresses out of their life, but they've also moved all the things that give them happiness and laughter and any sense of purpose and meaning in their life. So that's a very dangerous funnel to be going down. So trying to keep people connected and active and doing things that they enjoy, even when they don't especially want to, is a good idea. Gently, not forcing anybody, but just helping them understand that the funnel is a dangerous place for them to go down, and that you're concerned about the funnel, and that what you want to do, let's see if we can choose together something that we could do that might help re-regulate you. So that was one thing. The other is other things, a lot of secondary things that would tell you that they're having trouble, that they're using maladaptive techniques to try to manage the trauma. So that often includes alcohol, drugs, high level of control, high level of requiring everything to be very predictable and getting very angry when things are not predictable. So I'll meet you at 2 and you arrive at 2:15. There's a huge reaction to that. So then sometimes that can morph into, if you've got a bit of a tendency towards obsessive compulsive disorder, this can push that over into some obsessive compulsive symptoms. And then we might have the person who is doing the emotional numbing. So it's like they're there, but they're not there. They may be living this very numbed out life. The other thing that people do is workaholism. They may not do alcoholism or drugs, but they do workaholism. So they never take a holiday. They're busy, because every time they stop, it comes in. So that in order to avoid it coming in, they will keep themselves as busy as anything. And so the person who, there's sometimes other reasons why people won't do that. They may have ADHD, but the people who, and actually interestingly, ADHD and trauma are often misdiagnosed. So people who cannot stop, it's often a defensive maneuver in order to not let anything come in. So they just can never have a holiday, never relax. So those are the signs. And then social connection is one of the biggest things that we can help with. So having someone who understands, who isn't judging, who's connecting with you and supporting with you and encouraging you to come out and do some things that are helpful for you to re-regulate your body, whatever that would be. Go for a walk, go and do yoga together, go and do a mindfulness course together, go and go and have a laugh somewhere, do something that starts with a gentle thing, but not leaving them alone is probably the worst thing to do then. So, and there's sometimes, I've had people where they've been told to leave them alone. I've had military veterans, for instance, where they've been ordered to leave the person alone because they don't want to be triggered by being reminded of the army or whatever. And it's the worst thing that can happen. But they can change out of their army uniform if that's a problem, but they don't need to be abandoned as well, because secondary abandonment rather than support just makes it more chronic and exacerbates it. So just being there, if they don't want to go anywhere, then just be there. Make them a cup of tea, sit with them. Right? Talk about some other things, help them find that, and preferably have a laugh, because that releases endorphins, which is really good for regulation. But, just to help somebody feeling more alive, more connected, more hopeful, just doing that is probably the best thing you can do. And then finally get them to get some treatment.
Yeah, so I definitely hear you around social connection is very valuable, suggesting that they seek professional help. But, and just so that I didn't misunderstand what you said, let's just say someone was assaulted in a park. And now they were someone who loved going for a run in the park. Now they never want to step foot into a park. Um, would you recommend that someone say, "How about I go to the park with you?" Or do you kind of say, "No, this is in the realm of
No,
you
no,
work
no,
with a
actually,
professional." Yeah.
you have to know your person. But if you feel that you've got that sort of relationship, sure, you could certainly say, why don't we just go for a walk? We don't have to, let's not do the whole thing. Let's just go for a short walk, sit on a bench, look at the kids playing in the playground, whatever, just to desensitize it a little bit.
And open that funnel that you said, right?
Exactly. Open the funnel, start to connect that place with positive memories as well as the traumatic memories, and have some rewiring going on in the brain. So we're now also wiring in some positive experiences, and then just slowly and helping them relax while they're there, sit quietly. So it's better to, even if they go, no, I can't do it. It's just like, okay, let's just stay until how you're feeling comes down by half, and then we'll go. Because if you go at the height of the anxiety, that reinforces the fear of the place. Whereas if you are able to regulate and come down, that will make coming back next time, you'll be remembering how you left, rather than, we always remember how we left. So if we leave in a panic, we won't want to go back there because it's associated with panic. If we leave feeling calmer, then coming back is easier. So I wouldn't push anybody if they're starting to do that, but I would explain to them about, it's going to be really important we leave here calmer. So let's just do some breathing together, or let's just sit here for a bit. And when you feel a little bit better, I promise you we'll go. Right. So
I mean, and you mentioned this, you mentioned that there are different types of trauma, I think, with some of the examples that we've um, discussed, childhood trauma or, a one-off event. What about something like COVID-19, or what about the loss of a loved one, where you could almost say that everyone experienced that at some point in their life? Would you consider that a form of trauma, or is that kind of too much therapy speak?
well, I think, like, there are a lot of different traumas. So I tend to think of trauma as, I'll go through that first and then I will come to your question. There's impersonal trauma. So natural disasters, it means impersonal. Nobody's doing it to you. Natural disasters, a car accident, near drowning, those sorts of things are impersonal traumas. And they're often, I think, easier to treat than personal traumas. And then in personal traumas, we have personal traumas where it's been a stranger or someone we haven't got a particular relationship with. Or it's personal trauma where it's someone, particularly if it's someone where they are in a position where they are the ones who are supposed to uh, protect and comfort you. So in childhood, if it's a family member, in adulthood, it can also, when it's a family member, or it can be someone where you are feeling, it can sometimes even be an organization where you feel these people are responsible, I'm dependent on them for my safety, my protection, and for them to look after me, which actually is how the army sells itself. No, we're all family. So then when you get the source of the trauma has been either they have done something to you, so child abuse, for instance, from the very person who's supposed to be your carer. Um, Similarly, in domestic violence, where you're being traumatized by the person who's supposed to be your loving caretaker, or secondary abandonment, where the organization that's supposed to be responsible for looking after you abandons you when you've gone through a difficult situation, then this can really put it into a chronic situation. So, but there is a difference between stress and trauma. So, what's traumatic for one person may not be traumatic for another. So, what will overcome one person's coping mechanisms, put them into survival mode, and have difficulty re-regulating from that survival mode, that's trauma. Whereas someone else may have been able to get through COVID-19 or whatever it was by regulating themselves through it, finding other things to do, connecting on social media. It depends. It depends very much on who it is. Depends on what the trauma is, or what the situation is that may or may the potential trauma, who the person is, what their background is, how wide their brain is, what the meaning of this particular event has for them, because for some people, it means betrayal, and for other people, it's just a pain in the neck. Um, and the amount of support you have and connection that you have that might help you maintain your regulation. So it's very hard to say a particular thing would be traumatic. It very much depends on who, where, how, and why.
Mm. And so, in that context, what does recovery for someone who have, um, I guess, uh, engendered an event to be traumatic to them look like? How or do they just live with it forever, even after some sort of recovery period?
Yeah, yeah. I mean, well, some people do, but I tend to move that into in my mind clinically, and this is a very rough guide for me. But so if someone's walking into the room, uh, if I've got an adult who's had a stable background, stable enough background, has got a pretty good history of being able to regulate themselves through challenging times, who's just had an event that has been an overwhelming event, a car accident or near drowning or something, um, and this has happened in adulthood with that great background, then I would consider that treatment for them would be have a very good prognosis, and they're likely to fully recover, get back to the way they were, maybe have some post-traumatic growth, which we haven't talked about yet, but that's also can be, they can even feel that they're better for it in some ways. Not that you'd ever choose it as a way to grow, but it can be a great way to grow, change your priorities, recommit to values, get some more empathy for the people you used to judge, etc., through post-traumatic growth. So a single event in a pretty stable adult, uh, full recovery, I would think, is very much on the cards. Then we go into multiple events, and then or complex events where there are multiple aspects of it. So then I'd think about, have I got someone who can tell me about the multiple events separately? They can tell me about this event fully, and then we can move on to this event or this aspect of that very complex event, and then this aspect, so that we're going to be able to treat each event separately. Then that's going to take longer, but they still have probably got a reasonably wide window of tolerance, and we're going to be able to work through the complexity of what we're doing. So that will take longer, but it still has a very good prognosis. For those who have come in with multiple trauma, often starting in childhood, and then they've had adult events, unfortunately, people who've had adverse childhood experiences seem to be more vulnerable to having adverse adult experiences as well. So they come in with a multitude heartbreaking traumas in their life. They don't have a wide window of tolerance, so they're very easily triggered and very easily either shut down or agitated. They have difficulty keeping the events separate in their mind. So they start to tell you about one event, but before they've finished telling you about that one, they've gone on to another one. And before they finish that one, we're back into when they were a child. And before you finish that, we've come back to what was happening in adulthood. So it's difficult for them to keep track, and it's difficult for them to process it because every time they try, they get scattered off into all the other things. That's where I would go into the 3-phase treatment, and that can take years. And for some, we get to where we've got to where they're able to function well in life. They've made their peace with what has happened. They're not going to be who they would have been had that not happened, but they're forging and rebuilding who they are now. For others, there can be, there's different varieties of recovery, but depending on what it is they're bringing with them. That answer that question? I hope it does.
Yeah, it does. And, I guess obviously everyone's looking for the silver bullet. And one of the more popular therapy types you hear about in the context of trauma is EMDR. And you also talked about how for some people, amnesia happens because it's a way of coping to what's happened to them. And so they can't actually remember what's happened. Like you said, all they have is their body reacts when the phone rings and they don't know why. So what type of therapy would you say is best practice? Obviously acknowledging there are multiple best practice therapies, for example. Yeah.
So, I'm a great fan of EMDR, but I'm a great fan of EMDR in the context of having available to you a whole lot of other therapies as well, because the EMDR can sometimes get stalled or start looping, or the person needs you to switch across. Sometimes in the middle of an EMDR session, you need to go into a different treatment model. So, but I'm a great fan of EMDR, and EMDR can shorten treatment in ways that are astounding, really, where you could be doing talking treatment for years, and EMDR will cut through and get things sorted pretty quickly, especially for single adult trauma. EMDR is fantastic. So I think EMDR. The other thing, especially with those that have got amnesic things and maybe dissociation, you even before you start EMDR, you need to have a very good understanding about dissociation and be able to screen for dissociation and know how to manage dissociation. Dissociation is a whole different thing to talk about. But the more and more people have been learning more and more about treatment the last 20 years or so, it's become more and more evident that what we need are treatment modalities that include the body. So somatic experiencing or mindfulness-based core processing therapy, or something that's going to include the body, because as Bessel van der Kolk once said, the body holds the score, or the body keeps the score. So, and for a lot of people, they are actually coming in with bodily symptoms without any real memory. And so often working through in a very fractionated, safe way, working through from the body is often the treatment of choice for some people. So body-based treatments, EMDR, hypnosis, I'm also a great fan of. So they need to have as well as doing some cognitive interweaving as well. So they need to have, EMDR is great because it involves all those modalities. It involves the body, it involves cognitive reprocessing, and it involves being able to stay in the window of tolerance. But all of them need to have those elements, really. They need to, whatever you're using needs to involve the body, needs to involve cognitive processing, so that you're actually going to bring that memory through to remote memory. And they need to have, an ability to keep the person safe in the window of tolerance.
That sounds good. We've covered so many different topics in the context of trauma. What else, anything else, Jan, that you feel you'd love to share with us before we kind of close off?
I think one of the things, very quickly, because I know we are running out of time, but we haven't mentioned shame. And one of the things that is a constant visitor for people with PTSD or other, PTSD is not the only outcome from trauma. So you can also have other dissociative disorders, alcoholism, and drug abuse, etc., often trauma-based. And sitting aside that is nearly always shame. I've rarely treated someone who's been traumatized and gone into a chronic form of a trauma response to that, who hasn't got shame sitting with them. There's shame from what happened in the incident. There's shame about not recovering from the incident. There's shame about what you've been doing since the incident. There's just a whole lot of shame. And for people who've come through childhood adversity and childhood abuse, shame has started really early. And shame is not the same as guilt, right, or embarrassment. Shame is where guilt is where you know you've done something wrong. That can be in the picture as well sometimes. Um, but shame is about I'm wrong. There's something wrong with me. I'm inherently unlovable, or I'm inherently pathetic, or
Or they blame themselves for they're the reason for being abused, and
and
yeah.
or I'm useless, or if you really I know you think I'm okay, but if you ever got to know me, you would discover this deep, dark, massive horribleness inside me. So and often there's shame about I should have recovered. Other people recovered. Not everybody at work got PTSD, or not everybody. So there's a lot of shame about just even having PTSD or not having fully recovered, even though that's never your fault. So I think shame needs to be addressed all the way through, because shame just makes people hide what's going on, makes them less likely to seek treatment, less likely to talk about it, and it just buries itself deep into a toxic state.
But and so I guess, like you said, as you said, you've identified shame as such a core part. So what can someone do, either whether for themselves or someone they're supporting, or for the therapist working with them, to address this shame piece that you've
Yeah,
identified?
wow. I think we'd have to have a whole other session for what can we do about shame. I mean, shame is difficult because shame shame goes with hiding. Like, nobody wants to have shame exposed. So sometimes even talking about it is enough to make someone want to run for the hills. So there's it's a delicate thing talking about shame, but I think knowledge is power. So even knowing, as a result of just this few minutes, that this is part of the problem. This is part of the symptoms. This is not necessarily true. This is something that you would expect to happen, but shame is going to be in the picture, and that you need to guard against that, and you need to know and read, or talk to your therapist, or talk to your friends about the fact that shame is there, because the more shame gets into the light, gets discussed, gets owned, the less it becomes shame.
Yeah, totally. And so it's almost like saying a caveat statement that, you know, if someone experienced this, they also feel these moments of shame. And I want you to know that you shouldn't blame yourself, or you shouldn't think this way. It's your brain playing tricks on you, as a way of just, I think sometimes with shame is you're assuming nobody else is thinking and knowing that, and just putting it out there.
Yeah, I think that's right. I think normalizing it, recognizing it's likely to be there, offering to talk about it in a non-judgmental way, being able to explain why it's there and why it's not necessary. It's the more you can actually acknowledge that, allow them to see it as a symptom rather than a truth, um, then the better.
I saw this video where they talked about how in Korea they have the lowest rate of depression but the highest rate of suicide, and that shame is a disconnect because of the pressure of what it means to be the provider and to not fail. But then once you feel that you have, then suicide seems to be
Yeah,
the
yeah,
only
yeah.
way
There's
out.
no
Yeah.
comeback. There's no, yeah, and there's something inherently you're a failure, and toxic shame is a horrible place to live.
Okay. Well, I do want to end on a positive note. So, what's one thing that people can do if, in the context of whether they are going through trauma or they're supporting someone with trauma? What's one practical thing that they could take away?
Uh, okay, well, it's all about regulation. So it's all about recognizing when you're dysregulated, and learning skills, or helping someone else learn skills to regulate. The more you can regulate yourself, the more the brain is a great organ for survival. It's also a great organ for recovery. If you get out of the way and stop avoiding things, and you're able to help yourself re-regulate or help someone else, it will start to do its job, and it will start to do what needs to happen. And then if that's not happening, get treatment, because it's very treatable. So I would say it's never the end of the world. The worst thing to do is to avoid it. And the best thing to do is to forgive yourself and allow yourself to be helped with other people, because connection is everything.
Totally. Well, we love to end these things with one question, Jan. What is your one well-being practice that you do to stay mentally well?
You didn't tell me you were going to ask that. Oh, let me think. Uh, I think it's all about my friends. I think laughter is a huge regulating thing for me. So being with my friends that I know will make me laugh, um, that's what I do. And physical exercise. I always ensure that I'm getting physical regulation through physical exercise and laughter with my friends.
So, if you want to learn more about how Clearhead can support your workplace, or you have a burning mental health question that you'd like us to explore on the podcast, check us out at myclearhead.com and drop us a message. Love our content? Share it with a friend or leave us a comment on LinkedIn, Instagram, or Facebook. Thank you so much again for listening, and catch you on the next one.